Good morning. This is Elvis from the Chinese University of Hong Kong. Thanks the organizer to give me this chance to share you with our study entitled Prospective Comparative Evaluation of Optical Genome Mapping, Maypair Sequencing, and Chromosomal Microarray Analysis in Prenatal Genetic Diagnosis of Fetuses with Ultrasound Anomalies. I don't have any financial disclosure. For current cytogenomic analysis in prenatal diagnosis, we look for variants in aneuploidy, copy number variance, structural rearrangement, as well as region with absence of heterozygosity. In 2023, ACMG had published practical statement in detection of germline structural variants. Here's the table summarizing different methods and different detection scope, from karyotyping to CMA to sequencing, optical genome mapping, as well as long-read sequencing. Today, my presentation will mainly cover microarray, Maypair sequencing, optical genome mapping. For the other method, I will mainly talk about that in my next presentation on Thursday. So what would be the Maypair sequencing? Maypair sequencing is a method for revising the protocol for standard genome sequencing. Here's the diagram. For standard genome sequencing, we usually will have read 1 and read 2 from the same DNA. When we align the sequence to the genome, most of them, they will align to the same chromosome, but some of them, part of it align to chromosome A and the other will align to chromosome B. We call it chimeric read pair. Some of it will, by splitting, part of it align to chromosome A, part of it will align to the other chromosome. So we gather this method, these kinds of reads for following analysis. But for human genome, most of structural variants are mediated by repeat element. If we use standard genome sequencing method, for those one mediated by repetitive element, it will cause ambiguous alignment, which will reduce the sensitivity for structural variance detection. But we need to enlarge the DNA in order to identify the unique sequence. However, for standard library construction, we are not able to have the DNA as long as 5 kb. We need to make a circularization of the DNA in order to have the DNA sequence from these two segments for the sequencing. So end up library will contain the information from these two arms. What we look for copy number variance by using redact method. We look for structural rearrangement by using the discordant mapping read pair. We also look for region with absence of heterozygosity by using the genome typing ratio. Last year, we conducted the first back-to-back study by comparing the Maypair sequencing with CMA in prenatal diagnosis. Maypair sequencing not only have increased diagnostic yield, but also improved variance interpretation in 40% of the cases with positive finding reported by CMA. Recently, there's another method named the optical genome mapping have been introduced. It's a method utilize ultra-high molecular weight DNA over 150 kb with fluorescent labeled motif. The content will align to the reference and to indicate the differences for identifying structural variants as shown in this diagram. However, previous prenatal study only compared this method to CMA, but CMA is not a method with comparable detection scope. Here comes the purpose of the study. First, to evaluate the diagnostic utility, feasibility of OGM against chromosomal microarray Maypair sequencing in prenatal genetic diagnostic applications. Second, to assess the advantage and limitation of different methods. This table summarizes 3 methods we used in this study. Microarray, it only looks for copy number variance, and region with absence of heterozygosity by the probe-based design. For both main-pair sequencing and optical genome mapping, they can have the capability to detect rearrangement in addition to the detection scope of CMA. This is the workflow of the whole study. Overall, there were 233 fetuses with ultrasound anomalies detected. And because of the need for have ultra high molecular weight DNA extraction for optical genome mapping, we set up the culture for the test. In addition, we use uncultured DNA for maternal cell contamination study. After exclusion of those cases, we subject them independently for chromosomal microarray main-pair sequencing. As what I just mentioned, for microarray, it can only look for copy number variance, but for main-pair sequencing and optical genome mapping, in addition to copy number variance, we can identify structural rearrangement with or without copy number changes. For the inconsistent finding against different platforms, we use different methods like MLPA or RT-qPCR for the validation. Here are the summarized characteristics. Average gestational weight at the time of investigation was 20.6 weeks. Average maternal age was 34.1 years old. The majority case was amniotic free, and then the majority case with the indication will be isolated fetal structural anomalies. Here's the summary table. In the category of aneuploidy, we have inconsistent finding, mainly due to the culture differences. The pathogenic variant change, optical genome mapping, and CMA have the same finding, but main-pair sequencing have additional finding because of the small CNV involved. For the VUS, CMA report 6 cases of VUS, but 5 of them have been reclassified as likely denied by optical genome mapping and main-pair sequencing because of the information of structural orientation. And then for the balanced structural rearrangement, both methods detect 6 inversion. For the capability of AOH detection, 3 methods yield the same result. Here, this is a table summarizing 17 cases of discrepancy finding. I will use cases to demonstrate one by one. For the this is the case of male fetus have CMA report a partial gene gain involving the exons 3 to 22 of PHEX, which is known to be a haploinsufficiency gene, which inherited from the mother and classified as VUS because we don't know where the gene was disrupted. But for OGM and main-pair sequencing, both of them indicate this is the tandem duplication. So by this kind of scenario, the gene remain intact, unlikely contribute to the disease by a loss of function mechanism. For OGM and main-pair sequencing, both of them have the capability to resolve unbalanced rearrangement directly. This is the case that in a female fetus inherit XQ2A duplication, which overlap with the recurrent XQ2A duplication syndrome, but main-pair sequencing only report 2 smaller duplication, which have been highlighted in yellow color here, involve 2 genes RAB39B and TMLHE. Although main-pair sequencing have the capability to know the composition, it's difficult to know whether it follow scenario 1, which the orange color insert into the distal breakpoint of the blue color induce blue color duplication, or is in conjunction in a different scenario, which will be the blue color one insert into the the orange color one induce duplication. For optical genome mapping, because of the long consensus of the content. It can easily identify or define the scenario or follow the first one, which the segment 2 have insert into the segment 1 distal breakpoint. However, if we use optical genome mapping alone, they will only find motif inside this region. We are not able to know what will be the content inside. For the limitation, for both CMA and optical genome mapping, they are failed in detection of small deletion, likely because of the insufficient labels motif at this loci. Secondly, this is the case that the optical genome mapping report exon 45 of DMD deletion. However, for the sequencing method, it report intronic deletion which have been highlighted in yellow color here and have been validated by MLPA. It demonstrates the breakpoint margin of error of optical genome mapping. We summarize the advantage and limitation of both methods. For optical genome mapping, it can detect balanced, unbalanced SV. Long consensus map can help to assemble complex rearrangement, but the limitation is involving the difficulty in detecting small SV and the difficulty to define the breakpoint, and then the need of for using live cell for the ultra long DNA extraction. For MAPET sequencing, the advantage is to detect balanced and unbalanced structural variants, the higher breakpoint accuracy, but the limitation remains the difficulty of short read in assembling complex SV. For OGM application in prenatal, we resolve structural orientation of copy number variants to improve clinical interpretation. It needs cell culture. It needs another method for breakpoint validation. Both of them prolong the detection turnaround time. In conclusion, this is the first head-to-head comparison of 3 methods in prenatal diagnosis. MAPET sequencing outperforms CMM and optical genome mapping in variance detection and delineation, but have difficulty in assemble complex rearrangement. OGM did demonstrate feasibility of prenatal genetic diagnosis. However, its a disadvantage and limitation should be considered for clinical implementation. Lastly, I would like to acknowledge all the contributors for this study as well as the grant support. I would like to.
Hello, everyone. Now we are in the current hottest topic session. We started it right away with Dr. Dong's presentation. And just a quick housekeeping note that we will have 3 presentations, already 1 passed, and we have a Q&A after each of those. And you can leave your questions on the right in the Q&A section. We'll get to them straight away. So now, thank you, Dr. Dong, again for your presentation. I have one question for you. When you had those discordant cases across different platforms, and especially the US cases, how did you go about counseling the families?
This is a very good question because although this is a prospective study, but the consent we sign out, we will not report any additional finding from the new test. So the so-called, I will only report those one from the CMA as the clinical finding. But in the long term, for the clinical implementation, I would say that we might need additional tests. Like I use a practical case. OGM may have some of the error in finding the breakpoint, then we need to have the additional test. This will be the reality that in the clinical implementation that we need to be considered. Thank you.
Thank you so much for your answer. So, since we're short of time, I'll go straight to the next speaker. Now we will have Dr. Vaidehi Jobanputra, who is a board-certified clinical molecular geneticist and laboratory director specializing in prenatal genomic testing and cytogenomics. Her presentation is going to be about diagnostic yield of prenatal genome sequencing in the absence of fetal anomalies. Please go ahead.
Hi, good morning. Today I'll be presenting our data on the diagnostic yield of prenatal genome sequencing in pregnancies without fetal anomalies. This work comes from Genome Center, which is a collaboration between Mengmeng University, OBGYN department, and the Genome Center. The question that we want to address here is whether genome sequencing can provide clinically meaningful information even when there is no fetal anomaly identified or knowledge. So I'll start by making the question behind the study. In current prenatal diagnostic systems such as karyotype and Microarray are offered broadly, but genome sequencing is usually reserved for pregnancies with fetal anomalies on ultrasound. So because of that, we have the data on what genome sequencing adds when there is no fetal anomaly. So this is a gap addressed by our study on anomalous cohort. The aim of the study was to evaluate the diagnostic yield of routine prenatal genome sequencing in pregnancies without identified anomalies, and to understand whether these findings could still have meaningful implications for pregnancy, enabling or child management. For genome sequencing, the patients have been prenatal diagnostic testing with no fetal anomalies that were noted on imaging and time procedure were included. We excluded cases where there was an abnormal any fish findings, so we basically excluded cases with anomalies. For the reporting of the genome sequencing findings, we followed a very strict criteria which was developed by multidisciplinary team. We reported only on clinically relevant and significant findings. The reported findings were required to meet the three criteria that are shown here in the gray boxes. Variants were classified by ACT framework. We reported pathogenic and likely pathogenic variants in genes with a well-defined phenotype that were associated with a pediatric or neonatal onset condition, or where the variant had implications for maternal health at the time of childbirth. We did not report any variants of uncertain significance in this non-anomalous cohort. A total of 545 non-anomalous cases were consented to the study. Of these, 75 had a high a priori genetic disease risk. So this includes carrier couples, carrier of X-linked conditions, and parents with a known autosomal dominant condition. 24% of these high A priori risk cases were positive for the known genetic condition in the family, and therefore they were excluded from the overall analysis. So this leaves a total of 527 cases that we analyzed in this cohort. So this slide summarizes the characteristics of the final cohort that were analyzed. Of the 527 pregnancies, after excluding with a high a priori monogenic risk cases, most of these cases were analyzed as trios, where both fetus and the parental samples were available. Trio analysis helps and improves interpretation because here you can determine the inheritance and the phasing of the alleles and the phasing of the variants. Small numbers were analyzed as duos or proband-only cases. For the primary fetal sample, the cohort included both chorionic villi as well as amniotic fluid, with amniotic fluid making up a slightly larger proportion. Overall, this was a standard prenatal diagnostic cohort reflecting the type of samples and family structures encountered in routine prenatal practice. Here the slide is showing the turnaround time. Majority of the cases were reported within 2 weeks of receiving the samples. We were able to perform ultra-rapid testing within less than 1 week turnaround time when time was of essence. This slide here shows the key findings from the study. Of the 527 non-anomalous pregnancies, 9.5% had at least one reportable finding of potential medical significance. So these were not uncertain findings. These findings met strict reporting criteria and they were associated with severe profound neurocognitive or health impact. neonatal or infant management implication, or there was childhood medical management or surveillance need. So in practical terms, this means that about in 1 in 10 pregnancies without an identified fetal anomaly on ultrasound, there was a significant finding that could affect counseling, delivery planning, neonatal care, or early childhood management. So this suggests that genome sequencing can identify clinically meaningful diagnosis even before prenatal phenotype is visible. So shown here are type of findings that were identified by this testing. These findings were clinically diverse, and they included conditions with neonatal management implications such as the G6PD deficiency, aminoglycoside-induced autotoxicity, X-linked agammaglobulinemia, and the MODY-related glucose disorders. As well as there were conditions such as neurodevelopmental or structural outcomes such as Noonan syndrome, Onkor-Chung syndrome, thanatropic dysplasia. Many of these findings were inherited from an apparently unaffected parent, so while others were de novo, which highlights the value of fetal sequencing with parental analysis. One notable example here is of the thanatropic dysplasia. Here there's an FGFR3 pathogenic variant, which was identified at the time of CVS before an ultrasound phenotype would typically be expected. So this shows how genome sequencing can identify serious diagnosis before anomalies become apparent. So shown here are the findings that matter clinically. Several of the diagnoses identified by this testing had clear implications for neonatal or childhood management. For example, this X-linked agammaglobulinemia can prompt early immunology referral and planning for treatment, while the mitochondrial RNR1 related aminoglycoside sensitivity can change the medication choices. Other findings, they guide anticipatory care, such as monitoring of neonatal glucose abnormalities in the GCK or HNF1 related conditions, avoiding triggering anesthetics in the RYR1 related malignant hyperthermia susceptibility case, or considering fetal or postnatal imaging and neurology follow-up for the DCC related agenesis or of corpus callosum risk. In this cohort, we also identified a rare case of Moya-Moya disease. So here there is importance of surveillance because of the risk of stroke, intracerebral hemorrhage, particularly in the childhood. So this type of result could support early neurology referral and long-term monitoring. So the study showed that there were not just genetic results. These were findings with potential to change prenatal counseling, delivery planning, and medication exposure, neonatal evaluation, and long-term surveillance. This slide shows that puts the genome sequencing findings in the context of what is currently offered in routine prenatal and newborn screening. So among the cases with neonatal or childhood onset conditions, 72.2% would not have been detected by standard prenatal screening or diagnostic testing. More specifically, 100% were not included in the ACMG Tier 3 carrier screening guidelines, 92% were not included in the standard NIPT, and 72% were not detected by karyotype or chromosomal microarray, and 100% were not included in the universal newborn screening through RUSP. So the key point here is genome sequencing is not just simply duplicating the existing testing, it is identifying a different category of clinically significant conditions, many of which may have which will affect neonatal care, childhood management, or surveillance, but they would otherwise be missed in a non-anomalous pregnancy if not tested. To summarize, this study shows that genome sequencing in non-anomalous pregnancies can identify clinically significant genetic conditions even before ultrasound findings are present, or in cases where prenatal phenotype may never be obvious. These findings have potential value because they inform the prenatal counseling, delivery planning, neonatal evaluation, early treatment, and childhood surveillance. And importantly, many of these diagnoses would not have been detected by standard prenatal testing, screening, including karyotype, microarray, by carrier screening, or by newborn screening. So overall, this data suggests that genome sequencing has a potential to move beyond a test that is reserved for anomalous pregnancies. And this test has potential to become a first-tier prenatal diagnostic test. With this, I'd like to acknowledge everyone who contributed to the study, especially there are several members of my lab at the New York Genome Center. I also want to thank Dr. Wapner and his team in the Division of Women's Genetics Center at Columbia University. And this work was possible by funding from the Carson Family Trust and the Tao Foundation and so I'm thankful for their support for the study.
Thank you, Dr. Jobanputra, for sharing such interesting results from your study. Now we will start with Q&A. The first question from me while we wait others to come in. So how do you see this data changing the recommendations in the United States and globally, and on what timeline?
Yeah, I think this is a great question. There are other studies elsewhere, but they are doing a panel of a genome. Our study is very different from all other current studies because it's not a gene panel that we are calling off a genome, but it's truly a whole genome. And the reporting is based on the severe pediatric onset disease or maternal health implications. So this was based on a research study, and obviously this has to be expanded, and there's going to be more testing to be done before this becomes a recommendation. But the findings, as you see, are very interesting and certainly has importance.
Yeah, great. Thank you. So we have a couple of questions. First from Natalie Chandler. In the parental inherited cases, were the parents reviewed clinically and did they have clinical features?
So that's a great question. Sometimes, yes, they were evaluated clinically, and sometimes because of these findings, they were sent for further evaluation when the parents were not aware of the conditions that they themselves were carrying.
Okay, and the clinical evaluation for the parents, how did that go?
The study is very recent, so certainly it is still ongoing, and the parents are referred to different clinics. So we have some data coming in, and as we compile the results, we will be able to share.
Okay, thank you. So another question we have from Brigitte Fass. If they're asking if the analysis was restricted to part of the exome. Is that correct?
Yes, as I explained, no. This is not a part of the exome or a genome. It's full genome. It's not restricted to a set of genes or a panel of genes. The reporting is based on if the variant is pathogenic or likely pathogenic as per the ACMD framework and is associated with a severe pediatric onset condition or has maternal management implications. So it's really not a panel of a genome. It's really the findings from the whole genome.
Okay, yeah, thank you. I think we answered this question too. And if there are any other questions, please contact our speakers on our networking feature of the platform. And thank you so much again, Dr. Jobanputra. We will go to the next speaker now. So now we will have Dr. Mengmeng Shi, who is our final speaker for this session, and she's a postdoctoral fellow in the Department of Obstetrics and Gynecology in the Chinese University of Hong Kong. Her research focuses on clinical application of genome sequencing, identification of pathogenic variants, and the genetic basis of complex, phenotypically heterogeneous diseases. And her talk is about implementing prenatal genome sequencing in the routine care prospective study, evaluating diagnostic yield and clinical integration. So Dr. Shi, the floor is yours.
Hello everyone, this is Mengmeng Shi from the Chinese University of Hong Kong. And today, many thanks for the organizer to provide me this opportunity to present this work. The title for this study is Implementing Prenatal Genome Sequencing in Routine Care, a Prospective study evaluating diagnostic yield and clinical integration. I have no disclosure to make. And prenatal genetic diagnosis is to offer the risk for the fetus, whether it's affected by the genetic condition. And it's not only provide a diagnosis of genetic diagnosis, but also help for the informed pregnancy management and assess the recurrence risk. And the different prenatal genetic technologies has evolved from the karyotype for the common chromosomal anomalies to the CMA for the copy number variants, and also with the development of next generation sequencing. And compared to the other technologies, the genome sequencing provides a more comprehensive testing of majority of the genomic variants. And actually, there were some prenatal genome sequencing studies that provides a diagnosis rate around 50% to 34%. And they have supported the utility of this test in specific phenotypes, like the fetal structural anomalies. While most studies focus on the diagnostic yield and analytic validity, its lack of evidence on the real-world clinical implementation and workflow integration and practical challenges in routine prenatal care. So this study would like to evaluate the real-world implementation of genome sequencing at single center and to identify the practical challenges in integrating this tool into routine prenatal care, and also support the development of an evidence-based framework for this test as a first-line or cornerstone of diagnostic tool. There were some challenges for its implementation in routine care, like what kind of indication should be provided for the genome sequencing, and how we perform this test, whether we directly go for genome sequencing or sequentially after the standard testing with CMA or concurrently perform the test. Why it matters, how about the diagnostic rate, and how it impacts the decision-making of the parents. So this study starts from the 2021 to the end of the last year, and the trail-based genome sequencing was offered through 3 clinical pathways, like directly go to the genome sequencing after excluding the maternal contamination, and sequentially following after the standard testing with qPCR and CMA, or low-pass genome sequencing, or concurrently performed with the above test. The diagnostic utility and turnaround time were assessed across the different pathways, and the clinical follow-up of the pregnancy outcome was also reviewed. In total, there were 41 fetuses were recruited, and the median maternal age is 36 years, and the mean gestational age are 18 weeks. And the indications is representative, and including more than half of them with structural anomalies and severe IUGR, and 1/3 of them are affected for the isolated or mild or transient anomalies, including increased NT or mild ventricular megaly, and a small proportion for the symptomatic fetuses, like due to the anxiety of the parents. The overall diagnostic rate is around 30% by the 3 pathways. 6 of them are direct, go for genome sequencing, and sequentially in 16 cases, and concurrently in 19 cases. For the concurrent testing cases, the patient retains the option, they stop the test if they have the the standard testing also already reviewed the results. The overall diagnosis rate is 30%, and most of the diagnoses were single nucleotide changes, and remaining were pathogenic or copy number variants. And also, obviously, the diagnosis rate is also highest in the structural anomalies or severe IOGR. And all the copy number variants and AOH regions detected by the standard CMA were also detected by the genome sequencing. It's also identified 7 cases with candidate and certain findings at discussion by MDT meeting with compatible phenotype for the fetus. For the clinical value of the genome sequencing, let's take several examples. There were 2 cases with coexisting pathogenic copy number variants and single nucleotide changes. These coexisting findings could be missed by a single test or strictly sequential approach if the patient has made decision based on the standard testing. For this case is echogenic bowel or polydactyly with standard testing by low-pass genome sequencing revealed a duplication in a male pathogenic, duplication in a male fetus. And the prenatal genome sequencing, apart this pathogenic copy number variants, there were compound heterozygous variants identified in the IFT 56. And for this IFT 56 gene is a ciliopathy condition in autosomal recessive manner with biliary renal, neurological, and skeletal problems, quite compatible with the current fetus phenotype. And the copy number variant in this case is more likely to be an incidental finding. So another example is that for this case, it's a consanguineous marriage with CPC and bilateral telopates. And there were multiple chromosomes with absence of heterozygosity regions indicated by the CMA, while the genome sequencing clarified homozygous PIE02 exon deletion and within the AOH region consistent with the parental consanguinity. And this homozygous deletion might be too small to be captured by the CMA. Okay, so it's compare for the different clinical pathways, we can tell that, and it's obviously that the fetuses with structural anomalies or severe IOGR were more preferred to perform the direct or the concurrent testing. As in Hong Kong and in Singapore, the legal limit for the termination is before 24 gestational weeks. It's a very tight duration before they perform the morphology scan. And also, obviously, the direct and also the concurrent testing with the shortest turnaround time and also the comparable DNA input compared to sequential testing. So how about the genetic results impact the pregnancy outcome? Obviously, the cases has found the causative findings or highly candidate and certain findings. Most of the cases will choose the termination of the pregnancy, while for the cases without any genetic findings, most of them will keep pregnancy and result in live birth. There was only 1 case due to TOP due to the ultrasound issue, and 1 case TOP with unknown reason. So back to the challenges, how we handle these challenges based on our small cohort. How about the indications we select for the genome sequencing? The studies applying for the previous studies applying for the WES and GS to structural normal prenatal cohorts has reported that the variable but general low rates of abnormal genetic findings. And also in our cohort, among the 18 cases without major structural anomalies, also identified 3 molecular diagnoses, which are associated with severe neurological disorders or further structural abnormalities. But the evidence is still very limited for this case, how these structural normal cases will be benefited by the genome sequencing. So for this kind of cases, demanding thorough pre- and post-test genetic counseling and restricted analysis focused on the clinical significant disorders for if they choose genome sequencing. Then, how about how we perform the test, direct, sequential, or concurrently, and how it impacts the clinical measurement? For the sequential pathway, obviously resulting in the longest turnaround time and potentially prolonging the parental anxiety and complicating pregnancy management. Moreover, this approach risks overlooking an additional genetic findings. So when considering diagnostic robustness, TAT, and overall workflow efficiency, direct genome sequencing may be the most rapid and comprehensive diagnostic pathway for such complex cases, offering a decisive the advantage in time-sensitive clinical scenarios while ensuring a more comprehensive analysis. This study has several limitations as it's a single center cohort and with minimum sample size. It's obviously some selection bias. And the pathway selection was also influenced by the clinical context and the parental choice and potentially affecting the group comparability. And the absence of systematic postnatal long-term follow-up limits the comprehensive phenotype-genotype correlations. But it's still a real-world evaluation of prenatal genome sequencing implementation across 3 clinical pathways, providing a practical framework for its further integration into routine care. So the conclusions for this study is prenatal genome sequencing significantly improved diagnostic yield in fetuses with structural anomalies and other indications attributed to a comprehensive detection of genomic variants. And its successful integration into routine care requires flexible implementation strategies tailored to clinical urgency, resource availability, and specific phenotypic concerns. And the continued evolution of the genome sequencing will provide its transition from a specialized adjunct to a cornerstone of comprehensive precision-based prenatal diagnosis. And many thanks for the support for the 2 centers from the Chinese University and from the Singapore's team. And thank you very much. And any questions are welcomed. Thank you.
Thank you, Dr. Mengmeng Shi, for your presentation. So we have another presentation showing that genome sequencing provides a much better diagnostic rate. And you suggested the direct approach as one of the best options. How do you think right now, actually, in the regular, typical prenatal clinic, since your case was a little bit more specific, as you also mentioned yourself, what would be what of those pathways would be the most feasible right now, balancing the cost and turnaround time in a typical prenatal clinic?
Yeah, that's a very good question because we also meet challenges either as a clinician or as a laboratory technician. What kind of indication shall we go to the direct or still as sequentially as the current guideline has recommended after the inconclusive CMA or the standard testing. But based on this small cohort investigation, we still think if the cases only have a very tight the time string for them to choose the decide the further pregnancy management approach, they may choose better to choose direct genome sequencing to save time rather than to sequentially performed. But still, the guideline, I think the guideline might we still need some guideline for this kind of patients, because they still have meet any other meet other challenges, such as the insurance issues. Yeah.
Okay, yes, thank you. Yeah, definitely time is of an essence here in the prenatal diagnosis. And that was 41 pregnancies included, right? Are you continuing this study? Are you planning to include more pregnancies and fetuses?
Yes, we are trying to gathering more information and more cases, so that could be more representative for this kind of investigation.
Okay, thank you so much. So that brings us to the end of the session. If you have any questions, you can still reach out to our speakers on the networking feature of this platform. And thank you to all of the speakers for their excellent presentations on how the new sequencing and mapping technologies are reshaping prenatal diagnosis. Now we have a 30-minute break before the next session. So I encourage you all to visit the virtual poster hall to view the e-posters. Thank you so much.